So welcome everyone to the webinar of the College of Surgeons Court of Examiners to discuss the upcoming fellowship examination. I'd like to welcome you to the webinar. The aim of this is to provide you with some updates and some information about the effect of COVID-19 on the fellowship exam. I'd like to introduce myself. I'm Chris Pike, the Chairman of the Court of Examiners. I'm a member of council and I'm a general surgeon based in Queensland. The college acknowledges the traditional owners of the land throughout Australia and New Zealand on which you reside and their connection to the land, the waters, the community, and we pay our respects to their cultures and to their elders, both past and present and emerging, and tēnā koutou, tēnā koutou, tēnā koutou katoa for those from New Zealand. I'd like to also introduce the panel members this evening. So we have Professor Philip Carson, the Censor-in-Chief of the College, General Surgeon based in Darwin. We have Associate Professor Karen Fielding, College Counsellor, Deputy Chair of BSEC, and the Chair of the SIMG Committee, and an Orthopedic Surgeon based in Wagga Wagga, New South Wales. And we also have Dr. Charles Jenkinson, Chair of RACSTAR, Cardiothoracic Trainee based in Perth, but currently working in Sydney. So I'd like to thank the panel in advance for their contribution this evening and for taking time to answer questions. Also like to thank those of you who sent questions in already, some of which we would like to consider. And then you also have the ability to send questions on the GoToWebinar through the message and through the questions bar on the right-hand side of your screen there. And hopefully you have no difficulty mastering that technology. So our aim would be to answer as many questions as possible. So far there haven't been a massive number of questions sent in, considering the pathway that we've taken to get to this point, and we'll endeavour to answer as many as we can and post as many answers as we can on the COVID-19 Hub on the college website. The webinar is being recorded and will be uploaded onto the college website as well. I could just give a short synopsis of how we got here. To be honest, I think we all thought we might be in a better position when we held the fellowship exam in October last year. There were a large cohort of candidates, or at least trainees, who self-selected out of that, mainly in general surgery, and we were thankful there was very limited capacity to get through all of the candidates at the end of last year. And some of the teething problems that we've had at the beginning of this year have been trying to accommodate the number of candidates versus the number of exam opportunities available. We did initially have a plan thinking that the Trans-Tasman bubble would be open and thinking that we might all be vaccinated. We initially had a plan to run a standard exam as we would normally do with the two cities of Auckland and Brisbane, with everyone travelling to those two sites. Sadly, the Brisbane lockdown, followed by the Melbourne southern lockdown, made us feel, and then followed by the Auckland lockdown, made us feel that we couldn't really pursue those plans, and the decision was made that we should again run a dispersed exam rather similar to the one in October last year. Running simultaneous to this was the bubble of candidates that we have tried to manage our own best fashion. I appreciate that many of you have had to show a lot of patience with us in trying to get through the process. So we had not quite enough exam places for the number of people who were eligible to register for the exams, and we've had to work through a process whereby courts, especially general surgery, have increased their number of exam opportunities for the May sitting of the exam. So in effect, the general surgery court will be running two weekends sequentially in Sydney, and it'll be a Sydney-Auckland match on the first week and a Sydney rest of Australia match on the second weekend. And I'm thankful in advance to all the people in the college and all the candidates who've shown a lot of patience with us in trying to get that particular scenario up and running, so that almost all the candidates in Australia and New Zealand who are eligible will now have an opportunity to sit the exam. It may mean that there is a necessity for some candidates to travel, and the definite location of the travel, like for example, there are some jurisdictions where there are no examiners, and those candidates would have always had to travel somewhere. It may mean that they will have to travel to a slightly different place to where they were thinking. Like for example, someone from Darwin, instead of travelling to Brisbane, may have to travel to Adelaide as an alternative. Apart from those problems to do with the mismatch between a number of candidates and a number of exam positions, I think the Court of Examiners does have a fairly strong muscle or corporate memory of how to run the exams in a dispersed manner. The beauty of having the exam in your own state or in your own country is that there's less time spent travelling. There is a slight advantage in that. That there are definite things that the court is aware of when it comes to conflict of interest with the exams. And without too much ado, and apart from thanking you again, once again, for your patience for the process that we had to go through to make sure that all of the eligible registrants were able to have an exam opportunity as best we could, I might go to the questions as they start to come through. If I could start off the questioning, if I could turn initially to Professor Carson, the Censor-in-Chief. We have a question there. Is there a possible positive or negative bias introduced by being or not being examined by examiners in your own state? That's still on mute, I think, Phil.
That's not a good start. Is that better? Great. So that's a very good question that somebody's put in, and I know there's there's always anxiety, I guess, throughout both training and assessment about possible bias. And I just can assure you, I guess, that as the Court of Examiners, well, all the way through, but certainly at the Court of Examiners level, we take all sorts of measures and lots of measures to minimise bias. So the whole setup of the exam with 2 examiners, per session, this obviously helps to eliminate any single person bias. And the general conduct of the exam is to try to have as many different pairs of examiners as possible, examining every different section of the exam. Now, that's always been the case, and obviously in the smaller specialties that becomes more difficult when there's few candidates and fewer numbers, but even there's a relative excess number of examiners per candidate to try to ensure that happens. Now, during this this time of dispersed exams and COVID-induced change, that was one of the things upmost in our mind, to try to keep that risk, or reduce that risk of bias. And the bias, of course, can come from all sorts of things, and the examiners are trained very well to recognise their possible own bias and minimise that. But I guess the main thing we're talking about here is whether examiners are known to or whether the candidates are known to the examiners and vice versa, and whether previous knowledge can induce either positive or negative, assessment in that particular exam segment, which of course is meant to be very much a standalone assessment of your abilities to think and know about the important parts of your branch of surgery. So we do have that very much in mind. There's all sorts of things being done in these changed exams to try to bring alternate viewpoints, and that includes in some specialties having one of the examiners coming in as a video examiner. So I think in all specialties there's at least one real examiner in the room, but your second examiner in some specialties may be on a video link. We also use observers, and the observers don't take any part in actually marking, or they don't even speak up, when the marking's going on, but they're there to observe the process and to make sure that's, that the process and the discussion after the consensus mark and all that is done in a correct fashion. So there's all those sort of things in. And I know some of the questions. In fact, I've heard it myself from in some specialties who thought that going to the state where you've done your most of your training in, or done your bone school, for instance, or the equivalent in other specialties in, had some sort of advantage or disadvantage. And I just want to assure you that assure you to the utmost of ability that shouldn't be so, and is not so, in fact. So it doesn't matter which centre you go to, the standards and the standards will be the same and largely reproducible between centres. So just please take that anxiety away that it shouldn't matter where you end up going, you'll be examined to the same standard. And of course the standard we do examine to is to that of a first year consultant surgeon in your specialty. So we're not expecting you to be an expert in the more esoteric aspects of your specialty. We expect you to know the principles, of course, know about them, be able to diagnose conditions in that light, know all about them, know the principles of management, and particularly any safety and life-threatening aspects of that. But you won't be examined to be an expert in the most complicated aspects of your specialty. The whole point is to actually have you going out as an independent, qualified surgeon, as a safe surgeon to be practicing as an independent practitioner in the community. So that is the bar, and that should be reassuring too. So we want sensible, well thought answers from a colleague that we would be happy to go to or send our family member to, and know they'd be treated safely, and that person would seek expert help or other consultations appropriate, but certainly they'd be assessed and managed safely. So that's the bar we're looking for. Sorry, Chris, I did extended my brief there, but
thanks, Bill. And
come through.
Well, I just wonder if it's an appropriate time for you to add about the complexity of the questions and how they're set, and what I know you mentioned the level of a first-year consultant there. Did you want to talk about higher order thinking and that kind of thing? Or
I'd love to, Chris. So yeah, so I don't mean to downplay it in that. A first-year consultant surgeon is a mark that shouldn't be downplayed, and particular so in this exam that we're looking for this higher order thinking. So we assume by the time you've got to this stage in your training that you've got many of the facts that relate to your particular branch of surgery under control, and the knowledge is there. And the thing that makes a safe surgeon and a non-safe surgeon is this higher order thinking. It's the ability to look at all the facts, take all the seek and look for all the facts there, and then to synthesize them into a diagnosis initially and then a management plan. So the questions, as far as possible, are pushing towards that extra bit of thinking. So you mustn't, well, that's wrong. We're not supposed to say mustn't, are we? But don't approach it like an undergraduate when trying to just spill out everything you know about a particular subject or a particular question. What we want is a thoughtful answer from a colleague, a surgical colleague, talking about a difficult clinical problem or an anatomical problem or a pathological description, and we want a colleague-to-colleague sort of discussion demonstrating that higher order thinking, the ability to seek appropriate information, synthesize that in a way that takes into account all the nuances and the characteristics of that patient, including the cultural context, the social context, the other medical context. All those things are important. Don't just sort of hone down on, oh, they're just asking about this operation, or they're just asking about this fact that, is in my particular specialty. We want to be a safe surgeon. You need to take in all those other facts and have this colleague-to-colleague discussion at a high level, and that goes for the writtens as well as the Viva exam. So in the writtens, we don't want just lists from a book. We want a few basic, or a few facts as elicited by the question perhaps, but we're particularly looking for that synthesis and working up those higher order of thinking and problem solving.
Thanks, Phil. So less questions about lists and more questions about comparing and analysing, that kind of thing.
Yes.
So I might move on to some of the questions there. So two that have come through so far. Will the clinicals be conducted with real patients or computer-based, similar to the October exam? So the format of your specialty exam will be similar to the October exam. So, for example, general surgery, OH&S, orthopedics, none of them had real patients. Plastics, vascular and neurosurgery were the ones who kept real patients for their vivas. So the format will be identical to the October exam last year. I think there's a second question that is very similar to that. Clinical and operative photographs here. So your supervisors and your surgical training boards will have access to the exact format of clinical photographs. I think in plastics and reconstructive surgery there's a lot of clinical photographs as well as having patients, and a lot of imaging. And then one more question there, so we'll be examining live patients. That's right, I just had that one answered. There's a question here about the timing of the announcement of the results of the exam. So the format of the exam will be similar on the first weekend. The format will be similar to the New Zealand exam, where all the vivas and all the meetings are finished on the Sunday afternoon. And the second weekend, which is a purely Australian exam, all the meetings will not be finished until midway through the week after the exam. There will be a gap. Our main consideration is that we don't want to give people results in a situation where they may be vulnerable and may be isolated and may not have any support around them. And so very much closer to the exam, we'll find out what the size of that cohort is, the people who will need to be in isolation at the time the results should become available, and we'll be timing the results based purely around the most vulnerable of the cohort. But you'll be letting know the results as soon as we possibly can.
So Chris, just to clarify that, so it's likely to be, given the current uncertainty about travel restrictions and so far, the candidate should expect perhaps to hear the results 2 weeks after the exam, which is a departure from our normal practice. But that will be the default position, if you like, given that it is reasonably likely that there'll be some restrictions and some people may have to go into quarantine, and some of those people may not have passed their exam. And so I would just ask all your indulgence in that. It will be an anxious time waiting, but if you could just think of your colleagues getting some news they haven't passed and isolated from their families and supports, and that is the motivation for potentially delaying the results.
Thanks, Phil. Cardiothoracic surgery, I think cardiothoracic do not have live patients for this exam. They have videos and clinical photographs. How would the college help a candidate from exemption to travel in the case there is a lockdown in a particular city? I have to say timing is an issue here. The beauty of the dispersed exam is it's more likely that the most candidates will get through, but if there's a sudden lockdown on the day or in the days leading up to the exam, we will be completely at the behest of what the local COVID rules are. But for example, though, the college did extraordinarily well with the GSSE exam held in February or March this year. Both Melbourne and Auckland were locked down simultaneously, and the college, through their advocacy, were able to get special exemptions for the candidates to go and sit that exam at exam centres. And I expect the same amount of advocacy would occur should there be one particular centre go down.
So I think Karen, that's the message, isn't it, Chris? So certainly with that GSSE, it was pretty marvellous. The lockdown in Melbourne just happened on the Friday afternoon, I think, and the exam was due on the Wednesday the following week, and went straight to to government and other colleges who were having exams at the same time, and it was the same thing in Auckland. And so most people were, well, all people I think were able to sit the exam. And of course we can't guarantee that because nobody can guarantee anything in this age of COVID, but you can be reassured the college will be doing everything possible to get you an exam on the appointed day.
Karen, I might ask you a question without notice myself about the SIMGs, their travel plans, and some examiners in rural centres have difficulty with travel quarantining, is that right? Or there has been in the past?
Yes, so there was last year, especially from rural areas where, you know, the COVID numbers were obviously non-existent or significantly lower, and people were encouraged not to travel to the city because they couldn't return to work. But obviously that's certainly better at the moment, and I didn't hear of that affecting anyone in particular. But again, we would try and advocate on your behalf to your jurisdiction if you were told that you shouldn't travel.
So more questions, thanks very much. If the Viva component is delayed due to COVID, will we be told of our results of the written component? I think as per last year, if the Viva component is delayed, you will get a free pass to do the Viva at the next sitting. The written component won't really be analysed until all of the parts of the exam have been analysed altogether. So if you do the written and then the Vivas are cancelled due to COVID, you'll still get to do the Vivas again at the second sitting without having to do the written again. So that one written carries, but you won't get the result, that's all. The whole results come out at a single analysis of results.
Yeah, so that is different than the normal practice, isn't it, Chris? There. So normally, you know, the exam is seen as a whole, and so if you do fail any one segment of or you fail because you failed one segment, you do have to do the whole again. But because of this COVID-induced change, we're now doing, as Chris just said, holding over a written. But just to emphasise here, the exam is you don't get the results of the written, and then you don't know whether to do them again. Because the exam, when we mark the exam or when we make the final decision about whether you are a safe first-year surgeon or not to go ahead, we take into account the whole exam. And in fact, if you've done so poorly in some aspects of the written, you may still well pass if on looking at the blueprinting, similar areas of practice have been covered in other areas of the exam, and the examiners are able to be reassured that you are safe in that area, you can still get through. So it's to your advantage that you know, you're not given an early result of the written component, because subsequent performance can make a difference. Whether that is, you get what I mean. That's not the thing that's going to necessarily fail you if you've done well in other similar areas later on in the exam.
Thanks, Phil. The two Vivas, two weekends for the sitting of the general surgery Vivas, it's the last weekend in May and the first weekend in June. Will the clinical examinations for orthopedics be undertaken in Brisbane for the Australian candidates or state-based like in October 2020? It'll be the same as the state-based in October 2020. Look, to be fair, not all specialties are going to each state. There is still going to be some travel involved for some candidates, and I think orthopedics, from memory, will not be examining in Perth.
I think they are this time, Chris, from my memory, but it might.
No, you're correct. Yeah, no, you're correct. Yeah. I think general surgery is not examining in Perth. How will the, that's already answered that one. Don't quite have full mastery of this yet. There was some, may I clarify, is the Viva clinical component for the vascular exam no longer to be held in Brisbane? So I've got vascular surgery. Yes, there will be a cohort examined in Brisbane. The 3 centres for vascular appear to be Melbourne, Brisbane and Adelaide, unless things change again between now and then. But Brisbane, Melbourne and Adelaide seem to be the 3 centres for vascular. Sorry. Is there a way that the examiners as a group would evaluate or give a realistic patient scenario, or would it be formulated by an individual examiner? Well, I kind of, the Court of Examiners, each specialty gets together almost always in February each year and writes the whole exam, writes the exams for the whole of the year. Usually there are 2 sittings per specialty. I'd say a new exam is composed from scratch each year, and it's a conglomerate. It's never one examiner who writes the scenarios. It's always the same as those of you who are involved in university exams would know that perhaps if someone has some homework to do, they have to get the main stem of the question and a model answer, but then the whole group has to workshop it. I don't know if that answers that question, but they're definitely realistic patient scenarios because almost all of the material comes from the examiner's own clinical practices.
I think, Chris, I mean, reassure that person when to, yes, if you ever thought that an individual examiner would have that much influence, that's quite wrong. It's very much a group activity, and the way of getting the questions, in fact, as reliable and relevant and that is as possible is that the questions are workshopped by sometimes the whole specialty court. If it's a reasonable specialty court, and some of the bigger specialty courts, they'll break up into large groups and do that, but they're very well workshopped over a period of usually two solid days in February or March. And yeah, so everything that's done, both that and the model answers and the thoughts there's a lot of input from everybody. There's certainly no chance of some individual examiner getting on their hobby horse and going off, or their idiosyncratic approach. That the whole system is set up to stop that and to get as much input as possible and as much recognise as much variation of practice within a safe limit as possible.
Thanks, Phil. A further query about the timing of the results. Look, I think the maximum time after any sitting of the exam that we would intend to give the results would be 2 weeks. So it is possible the people who sit in Sydney on the first weekend will get their results before the people who sat in Sydney on the second weekend. Just the same as the candidate in Auckland who sits one weekend get their results before the candidates who sit in Australia the next weekend. Can we elect to do the computer version of the written general surgery exam? Well, to be fair, the Court of Examiners would prefer that all of the writtens are done as computer-based. There are some courts that still allow handwriting or pencil and paper or pen and paper. And in fact, one of the great strengths of our exam is that we in the event of a venue failure, we've always had the opportunity to circulate a paper-based version of the exam. However, the court of, at least the Court of Examiners would prefer that the exams were done computer-based and typewritten as opposed to written. And there are some specialties which insist on some paper-based content, such as plastic surgery. You have to draw diagrams, and it's still allowed in orthopedics and general rule computer-based exams. Charles, I might ask you a question without notice there. Charles, your exam is a totally typed exam, isn't it? You don't get to do paper-based?
Yeah, it is typed. There's classically also been the opportunity for diagrams, etc., to be drawn on pieces of paper, but Predominantly it's typed, and it's moving towards 100% typed, is my understanding.
Can I just add to that too? Yeah, I'm a little bit, well, I was surprised to see that question still being asked for at least 3 and probably 4 years, I think, on the website, and certainly we've endeavoured to transmit to you that the exam, the written part of the exam, is going to electronic delivery, and that is the preferred thing. We had some misgivings initially about the stability of the platform, and they've been largely overcome. And certainly, as the courts have moved to that, the feedback from examiners is that it's very much more legible and fair to mark. In surgeons' writings or doctors' writings generally are often bad, and it's terrible to have either failing or the examiners being anxious about having passed a person, based on inability to read handwriting. So that's one reason. The other thing, it became more stable platform, and a more, there's less chance of error in terms of mixing up papers and so forth. So that was another pragmatic reason for going it. And the other philosophical reason under our undergirding our reasoning there was that really in modern, hospital-based medicine, as in fact even community-based medicine, some facility with word processing is really part of medicine. So I know, especially for some of you older candidates and SMIGs, you feel disadvantaged, and I am totally empathic with that. But we've all had to, in our clinical practice, obviously learn to put things in the computer, and that will only increase. So the exam is in fact aligning with modern practice, and you could almost see that word processing capability is not assessed per se, but really it should be taken as a part of a modern practitioner.
Karen, you want to jump in there though? Oh, on mute, I think still.
That if you do have a major problem and you have a reasonable request to do your exam in writing, that will definitely be considered at the college. I certainly do know of a few SIMGs who have had some issues, particularly, when English is not their first language, using the computer, and they have preferred to write. So if you do have a problem, or not a problem, but an issue, and you would like that to be looked at, then you must just get in touch with us.
So there is a special policy, in fact, about consideration for a reasonable adjustment, and that's the policy you need to use, and it needs to be in well before the sitting of the exam. And it's best, I guess it's easiest to approve if there's actually some specific medical or psychological reason why typing and or writing is not, whichever one you're asking for, is disadvantages you in some way. But certainly during this time of COVID, there has been more generous determinations too. So certainly, that's an avenue available. But I'd encourage you, all to think about getting that. It's clearly too late for this coming exam for some of you, but in looking to the future, that is the way it's going.
Thanks, Phil. So some postgraduate fellowship programs, e.g. ANSCOSA, have scheduled interviews in Melbourne on the 2nd of June. Prerequisites to the interview is passing the FECS examination, with the subspecialty societies notified and asked to delay the interviews due to delay in exam results. Look, I think there will be some communication between the Court of Examiners and the subspecialty societies. I'm sure they would have an easy workaround for candidates who have just sat for the fellowship and are pending results. I would feel very confident that with just a little bit of communication between the court and the societies, that won't be a barrier to the progression of your careers. How the results be communicated, I think that's been answered. Thanks very much, Mark. If everyone is vaccinated, both candidate and examiners, will the exam continue? Yes, I would think that would be. I think that would be the dream opportunity to continue all of the exams in every in all of its formats if both candidates and examiners are all vaccinated. I expect most of us will be in the 1B group, and I suspect that most of us will be vaccinated, or at least have had our first vaccinations by the time of the virus, both examiners who are all surgeons in practice and candidates who are all hospital workers. Urology clinical exams will presumably be state-based again as in October 2020. Yep, so I think for urology we've got Melbourne, Brisbane, Sydney and Adelaide, as well as New Zealand. Although once again I think there was some talk about Perth as well, depending on the numbers there. Will the scenarios be the same? Will the scenarios be the same for all exam locations, even if delivered online? I.e., do the first and second weekends in Sydney have the same scenarios? No, the General Surgery Court diligently and deliberately write 3 separate exams at the start of every year. So 1 for New Zealand and 2 for Australia. So there'll be 3 separate exams.
So Chris, just underlying that's, once again perhaps represents a fairly a view of the exam. We want to reassure candidates, I guess, that the exams are separate. So you would be totally unfair, obviously, to have the same scenarios coming up a week later, and where those candidates could find out from the previous candidates what was on. But once again, all the exams are set to the same passing standard. So there is a reliability within the exam to examine to the same standard, but there's no way you have the exact exam repeated the next week. And as you all know, in your preparation for the exam, one of the preparations is looking at past exams, so general themes and common types of questions come up time and time again, and that should just be part of your DNA by now. But you certainly won't be necessarily able to predict, which particular areas will be examined on any particular exam, but they'll be examined with that same question in mind. Does this person know enough about this particular area to be a safe, independent practitioner?
Thanks, Phil. And look, perhaps the point of the question was whether, the real difficulty in running the Sydney and Auckland exams at the same time is that they will be the same exam, and we'll need candidates to be quarantined so that the Aucklanders can't phone the Sydney candidates, and the Sydney candidates can't phone the Auckland candidates, I guess. But that will be the Auckland and first weekend in Sydney will be the same exam, but they'll be staggered so that it's a safe way to do the exam.
Can I just make a comment, Chris, while you're looking for your next question?
Yeah, please, Karen.
Just in support of our SIMGs, can I just implore you all to try and access some pre-exam practice? We have talked to all the specialty training boards, and they've all assured us at the college that they're all very welcoming of all the SIMGs to the exam practice, and that will certainly help you to navigate the process.
Thanks, Karen. Question about will there be 2 sittings for the exam? I think that's been answered by Mike. Is we feel confident if the pass rate runs at the current pass rate that there'll be 2 safe exams this year, one sort of May, June, the next one in September, and that we should have sufficient exam places for everyone this year regardless. Why are there no model answers published for the exam questions asked as each examiner's practice? Why are there no model answers published for the exams questions asked as each examiner's practice varies? Well, look, to be fair, there are model answers written for each of the exam questions which all the examiners have to mark to. So the questions, as I say, composed afresh every year, do come with model answers. You might ask, why don't we ever allow the publication of model answers from past papers? And maybe that's something that the court would look into everyone thought that was a good learning process. It certainly would show you the higher order thinking and the complexity that we're hoping to mark to. Phil, did you want to say anything about that? We've never done that, have we? We've never published model answers in the past.
So I guess the danger is that at this level, there's often no within the model answer is put there so that and that's discussed well in the courts so that there is general agreement. These are the principles, but it's very much about principles. And if a person comes with a variation, and certainly in the Viva, they are able to explain that to the justify that to the examiners to the extent that that is thought to be safe practice by those examiners, they will still pass. There's this conversation between colleagues, and variation is allowed if it's justifiable and it's is safe. So at this level, we don't want a whole lot of little 2-page things saying this is the only truth on this particular topic. So that would be one reason for avoiding publishing. So the model answers are a guide for the examiners. They're not it's not the whole reason for having expert examiners, I guess, is that they can judge the candidate against the model answer, but make appropriate safe allowances. And I think if we made it into a book of correct answers, that would be a wrong message for you at this stage of you're entering life, where life is not like that. It's not all confined in the covers of a book. It's talking about real problems, real patient problems, real clinical problems, and we want to be engaging with you as a practitioner where uncertainty is part of life.
The examiners will have worked out the standard, which they think is a pass-fail standard, and all the examiners around both countries will examine to that level for any given question. And Mark's just pointed out we do provide past papers. Mark, thanks for that. Thanks for that information. When will candidates receive confirmation of the location for the clinical exam for orthopedics? As a New South Wales trainee, I may have to travel to Adelaide. When will this be confirmed? Is there still a possibility that as a New South Wales trainee that I may be able to sit the clinical exam in Sydney? Thank you. A good question. Look, the finer detail on that is still not 100% bedded down. We appreciate that you need to make travel plans, and this is high in our minds that we haven't bedded down the final numbers in each exam city, but all I can do is reassure that that is our next piece of business as a court. We're now meeting quite regularly to workshop all of these problems leading up to our next dispersed exam, and that's our next point of business. Would we be allowed more papers rather than 4 sides to draw more flowcharts or diagrams? Okay, I think that's a good question about the way you answer the written papers. I think in each exam centre, if you're answering with pen and paper, that you are allowed unlimited numbers of exam booklets. I think depending on what specialty you're in, if there's a short answer, if there's some are kind of like spot questions or ISOIs, depending on which specialty you're in, they're very short answers. They usually have a fairly brief stem, and you normally have about 4 or 5 minutes to answer those questions only. And the medium questions, you would kind of wonder to yourself, would you need more than 4 bits of paper to answer? But as far as I understand, there's unlimited numbers of exam booklets that you can fill up to answer the questions which are being sat, at least been asked.
That's certainly so for the electronic version too. I think there's no limit, but obviously the limit is time, and you're pacing yourself and not going overboard on one question and then compromising the others. So it's a very important part of exam technique is obviously looking at beforehand, working out what you need to do in the time, and not spending all your time and putting all your well, it's a very basic exam thing. If you actually end up missing a question at the end, it's very hard to pass. So it's very important to answer all questions, which will naturally limit the amount you can write about any one.
Thanks, Phil. I think time management is an important thing, and I think if at all possible, you should all have the opportunity to try to sit a practice written paper between now and when the writtens are on. It does give you an idea of how much you can write in a 2-hour period. I think time management becomes a very important part of all this. It's safe to assume that the candidates sitting at the end of May and those sitting in June will be sitting different papers. Yep. And that every candidate in each weekend would be going through the same exam cases. Yes, every candidate sitting on the same weekend will be going through the same cases, with the minor exception of those who still have live patients who may have different patients in different exam centres. So that would be for neurosurgery, plastics and vascular. Depending on where you're sitting, you may have different patients to the ones in the other centres.
And that of course, just to reassure, that's no different than if it was all in one centre, because there would be a pool of patients and not all candidates would see every patient. So that is unaltered by the current different arrangements.
Then we've got a question about if you come across a question you would rather do a flow chart for, what do you do? And that's been answered by Mark. So you'll be given the ability to draw during the exam. Those bits of paper can be scanned in. If there'll be 2 sittings this year, in the scenario the first sitting viva is postponed because of COVID, the candidate will only sit the viva in the second sittings, having done the written in the first sittings. Yes, that's correct. That's what we said earlier. That's good. Sorry, please clarify the clinical examination location for general surgery. So general surgery does not have live patients this year. For the clinical exams, there are computer-based scenarios. There are 6 shorter ones and 2 longer ones, and the GSA, the training board, would be able to help you with the format and perhaps some previous exam questions that you can base that on, but it would be the equivalent of what used to be the short cases and the longer cases. How do we access materials for the exam prep? Is Dr. Fielding referring to the RAC's website materials? Oh, Karen, that's a question for you.
No, I was referring to the Specialty Training Board's programs. Some of them have training programs, your local bone school, your local hospital, your groups of trainees that are doing their pre-exam prep to make sure that you get involved. But you can look at the online, absolutely you should look at the stuff on the college website as well. But I was thinking more some face-to-face and getting into a learning group with trainees in your specialty.
Thanks, Karen. As of now, the Cardiothoracic viva is planned for Brisbane for everyone in June. I'm training in Adelaide. Do I still have to travel to Brisbane? At the moment, that is the situation. The number of candidates for cardiothoracic is the same size as a very small hub. So I think it's something like 9 candidates. The Cardiothoracic Court do have alternative plans if Brisbane is in a sudden lockdown, and they would be communicated to you in a COVID-safe way at the time that a decision is made. But at the moment, Cardiothoracic are travelling to Brisbane for that. Are we allowed to type during the 10 minutes reading time? Okay, now someone might have to help me here. Someone from the exams department?
No. No. Yes, you're not allowed to start answering in the reading time. That's by definition. Thanks,
Phil. Is limited use of dot points in writing orthopedic essays acceptable? So I would, without having a limit, an in-depth knowledge of the orthopedic exams, I have to say the content of your argument is far more important than the number of words that you put down on paper. I think they'll need to see that you've appreciated the complexity of the question. So the STEM will paint a particular way that you're supposed to answer the question, and your dot points or your writing should cover all of the main points, all of the suitable alternatives, and all of the things which should be avoided depending on the stem of the question. But dot points should be as acceptable as any other form of essay prose. There aren't any more questions come through here. There were a number of questions submitted prior to the webinar, mainly about the anatomy exam, whether it's still assessed in the written papers or whether it's fallen out of the written papers. Each of the written papers will have a generic question which is common to each of the specialties. So each sitting of the exam will have a generic question answered by a candidate about general surgical, not general surgery, but surgery in general, the practice of surgery in general, or things which are common to each specialty. That's a direct requirement of the Australian Medical Council when they accredited our college educationally, that we have a standard question which is answered by each surgical candidate. The generic question has pushed the specific anatomy question out of the general surgery medium length questions, or short essay questions, so to speak. And anatomy is examined in separate little subcomponents of the written in general surgery, and it's also examined as a whole separate viva in the form of clinical scenarios and imaging. The anatomy does not now include a HOROS in general surgery. The anatomy includes only PowerPoint slides. There's no scrolling necessary. The anatomy in cardiothoracic, for example, Charles, you might want to answer that. It's done as a whole separate viva, isn't it?
Yes, it is. So there is the mid-set anatomy viva. What we've been told from the cardiothoracic court again and again is that anatomy as it relates to a particular clinical scenario remains accessible. So for instance, if it's anatomy related to a thoracic lung resection, if it's actually related to the question in the viva, it remains accessible. However, the majority of the anatomy is tackled at the mid-set exam.
Thanks, Charles. Question here regarding the new generic question. Is it counted this time? How is it weighted? The weighting will be identical to every other component of the same exam. So if it's part of the written papers, it's weighted the same as every other question in the written paper, and it is counted for this exam.
I just you can just add in there, Chris. The the exam format lends itself best to measuring some competencies, particularly clinical reasoning and medical expertise, but we've increasingly increasingly sought to have it covering the other competencies too. Some of those are obviously best measured in the in-training assessments. But to keep the exam both relevant and also to emphasise, I guess, the importance we take all those other competencies, they are accessible in the exam too. So when you're talking about, anatomy, even some of those other competencies will be looked at, including, scholarship and what else, communication and all the sort of thing will come in place. And certainly the generic question was put in there partly to emphasise that to you, that these other non-technical competencies, if you like, are still examinable, and we want you to be expert in all competencies. So, and that will be probably a direction the exam will continue to evolve into.
Thanks, Bill. Look, I think we're getting close to time. Without any pressing questions coming through, we haven't made a definite plan to hold further webinars, but they have in the past been shown to be quite useful. So I think it's highly likely that there will be at least one more webinar before the fellowship exams in the mid-year. I know the writtens are close upon us, and there may be questions that you all need answered between the writtens and the vivas. In the meantime, though, without setting a definite date for that next webinar, if I could take this opportunity to thank the college staff who've prepared the material for us for this webinar, and I'll also thank the panelists here this evening. So Professor Phil Carson, Censor-in-Chief of the College, Associate Professor Karen Fielding, Deputy Chair of BSET in charge of the Specialist International Medical Graduate Committee, and also Dr. Charles Jenkinson, the Chair of RACSTAR, for your generosity in answering the questions here this evening. And thank you all for the questions that you asked us, and thank you for the opportunity you gave us to answer them. Thanks, everyone.
We'll see you, and all the best.
All the best. Good luck. Thank you.